So how can you switch the slides, Pierre?
It should be automatic. Yes, Zohar. And to switch, you can utilize this one. To go forward.
Well, it will be better, I think. So thank you very much, first of all, Pierre, Giorgio, and Carl, for this lovely session. And my talk is on retinal vasculitis. So retinal vasculitis is actually an inflammation of the retinal vasculature in which we should always see an evidence of ocular inflammation. And this is per the Sun classification. It may involve the retinal arteries, veins, and/or capillaries, and may present as an occlusive or non-occlusive disease. The diagnosis is based on clinical examination in which we are looking for the presence of perivascular sheathing, and in cases of an occlusive disease, for signs of ischemia, including the presence of cotton wool spots, intraretinal hemorrhages, and in late-stage disease, also neovascularization. The most important imaging tool, as Pierre told us, is the fluorescein angiogram, in which we are looking for the presence of vascular leakage, and nowadays we prefer to use the ultra-wide-field fluorescein angiogram. In cases of an occlusive disease, we are looking for the presence of vascular occlusion. We also may use the OCT for quantitative assessment of perivascular retinal thickness, and also the OCTA for the presence of capillary plexus dropout and enlarged fuzz, and the presence of telangiectatic and Schwann vessels in cases of an occlusive disease. It is very important to know that it may be associated with various systemic and ophthalmic diseases. And this is a nice scheme of the pathophysiology and influencing factors in retinal vasculitis. So we have various genetic factors, various endogenous and exogenous factors that trigger the immune system, and this results in tissue damage and endothelial dysfunction vasculitis. There are various infectious diseases that may cause retinal vasculitis. And these include lots of bacterial infections, as we all know, like syphilis, TB, cat scratch disease, borreliosis, and more. Viral infection, and recently we all know about the COVID-19 infection that also caused retinal vasculitis, in addition to herpetic diseases and more. Parasitic infection, and the most common is toxoplasmosis, and also some fungal infection. And these are some cases of my patients. This is a 35-year-old male with vision of 6 on 12, and he came with the appearance of neuroretinitis and a plaque of retinitis, and you can see very nice the picture that shows us that he had an occluded vein and artery with severe capillary non-perfusion area. So this is an example of cat scratch disease with an occlusive vasculitis. In the case of syphilitic uveitis, a patient who was a 30-year-old male, he came with bilateral vitritis. In the right eye, he had macular edema, a posterior plaque with chorioretinitis. In the left eye, he had neuroretinitis, and in both eyes, as you can see, a non-occlusive phlebitis. And another case of toxoplasmosis of a 24-year-old female. You can see that she had a toxoscar. However, she had a new foveal lesion, and you can appreciate that she had also some occluded arteries above the optic nerve. And another case of toxoplasmosis, this time in a patient with HIV with quite good CD4 counts, and you can see the cheilitis arteriolitis, which are accumulations of periarterial exudates, which is quite typical to be seen in toxoplasmosis, and she had also occluded arteries. We have also some, of course, non-infectious diseases that may be related to retinal vasculitis. And these include systemic vasculitis and systemic inflammatory diseases. But it is important to note that patients with retinal vasculitis will very rarely have systemic vasculitis. One exception is, of course, Behçet disease, in which one of the most common presentation is retinal vasculitis with occlusive retinal vasculitis. Retinal vasculitis may be also classified according to the type of the involved vessels. So in many cases, we can see phlebitis in patients with Behçet, sarcoidosis, MS, and infectious TB and syphilis. Arthritis is most common in patients with SLE, pan-GPA, and infectious acute retinal necrosis and toxoplasmosis. And more examples from my patient. This is a patient with Behçet, a 33-year-old female. She came with vitritis, severe macular edema, and frosted branchitis, as you can see in this picture, which was actually a very large inferior branch vein occlusion. And you can see very nice, after good treatment with corticosteroids and anti-TNFs, 1 year post-presentation, there was no active uveitis, but we can certainly see the occluded vessel. And the patient with sarcoidosis, a 43-year-old female, we can see very nice that she had iris nodules in both eyes and very nice keratic precipitates, large ones, and segmental non-occlusive peripheral phlebitis. And another patient with systemic lupus erythematosus, a 40-year-old male, you can see that he came with vitritis. He had also macular edema and phlebitis, which is quite less typical for SLE. Crohn's disease, you can see a very impressive picture of severe bilateral peripheral occlusive vasculitis. And I see some patients with Crohn's disease coming like this, and this is, of course, devastating, and we need to treat them fast. There are also some isolated ocular disorders that may cause retinal vasculitis, and these include Behçet chorioretinopathy, ARVAN, parasplenitis, in which we have a peripheral vasculitis, Hill's disease, and acute multifocal hemorrhagic retinal vasculitis. And also, it may be seen post-vaccinations. And also recently, we had several cases post the COVID vaccine, post the messenger RNA vaccines. And also, unfortunately, post various intraocular injection. And we also heard about the intravitreal bolosizumab that unfortunately caused very severe occlusive and also non-occlusive vasculitis. And also after the use of vancomycin as an intravitreal and intracameral injection, causing hemorrhagic occlusive retinal vasculitis. And I heard recently, and I think that maybe also some of you, about the use of intravitreal faricimab that unfortunately may also cause retinal vasculitis, but we are fortunate, but it is uncommon. There are also some drugs that may cause vasculitis, mainly the immune checkpoint inhibitors. And this is a nice case of Behçet chorioretinopathy with the typically perineural retinal vascular leakage pattern, which is leakage which is coming from the optic nerve through the major retinal arcades, and it is not involving the periphery. And there was a recent publication that showed that it is quite prevalent among Behçet patients, and it is seen earlier in the disease course with a high positive predictive value for the disease. And this is a very sad case of an occlusive vasculitis post the use of brolucizumab injection for DME. And what happened here, that 2 weeks post the 9th injection, the patient came with anterior uveitis and the combined central retinal vein and artery occlusion, and unfortunately, he lost his sight. How do we approach to achieve the right disease diagnosis? So we need always to have a multidisciplinary approach. The laboratory workup should be based on a differential diagnosis, which is derived from a detailed history, review of systems, and of course, physical examination. When we evaluate the patients who have a suspicion for infectious retinal vasculitis, we should always consider taking ocular and blood samples for culture, serologic tests, PCR testing, and also TB, of course. And for non-infectious diseases, blood and urine test, chest X-ray, chest CT, and head MRI, of course, according to the specific case. The goal of treatment is the suppression of the intraocular inflammation in order to prevent visual loss and long-term complications. But we should note that therapy may not be required for all cases. So cases with very mild disease activity and preserved visual acuity can also be followed up with no active treatment. Regarding treatment guidelines, they are not well defined due to lack of well-designed clinical trials. But we should also know that for infectious retinal vasculitis, we should always treat with an antimicrobial treatment and should add also sometimes corticosteroids. And for non-infectious disease, always to use immunosuppressive treatments. The mainstay are corticosteroids, but in many cases, we do add other immunosuppressives. And of course, nowadays, the use of biologic treatments with the TNF-alpha inhibitors and the IL-6 inhibitors. And this is a nice study from the States that showed that both infliximab and tocilizumab infusions showed statistically significant improvement of non-infectious retinal vasculitis, as was shown by FA scoring. And also, they concluded that tocilizumab may be an alternative in patients who failed infliximab. And here are some nice pictures showing very good results with the use of infliximab and tocilizumab in these patients. We should also consider the use of laser photocoagulation as prophylactic treatment in cases with significant capillary non-perfusion with no evidence of neovascularization, and to consider to add anti-VEGF injections if there is already a neovascularization in order to try to prevent vitreous hemorrhage and neovascular glaucoma. We should also consider vitrectomy in cases of non-clearing vitreous hemorrhage and to control massive inflammation, and also if there is a tractional retinal detachment. So in summary, retinal vasculitis can be a manifestation of a systemic or ocular inflammatory disorder. We should always conduct a thorough anamnesis, systemic and ocular examination, including, of course, the use of multimodal imaging in order to achieve the correct disease diagnosis. And the prompt and accurate diagnosis is crucial and enables us to provide the adequate treatment for our patients. I thank you very much for your listening. Thank you.
Thank you. Thank you very much, Zohar, for the beautiful presentation. While it was very tough to get better in quality compared to the last